Greetings, everyone. Thank you so much for attending the latest in the MDisability provider webinar. I want to welcome all of you. My name is Liz Katz. I'm the science communicator for the Department of Family Medicine and also do promotion for the Department of Family Medicine as well as MDisability. Just so that you know, I'm a middle-aged white woman, sort of medium length, blondish brown hair. And so I want to let you all know that today's webinar is going to be moderated by Dr. Tyler James. Dr. James is an assistant professor of family medicine at the University of Michigan and is the acting director of MDisability, while Dr. McKee is on sabbatical. Just a few housekeeping issues. For those of you who may be experiencing technical issues, please mention that in the chat. And for those who have questions during our presentation, please insert those into the Q&A. And at this time, I would like to introduce Dr. Tyler James.
Thank you so much, Liz, and thank you all for attending today's Provider Series webinar. The MDisability Provider Webinar Series is hosted by and for primary care medical professionals who seek information on how to care for patients with disabilities. Our goal is to provide clinical care insights, tools, and resources across the spectrum of physical, sensory, intellectual, and developmental disabilities. We host these webinars quarterly and provide live captioning. These webinars are provided free of charge with the generous support of the Robert J. Fisher, MD Family Medicine Fund. Today's presentation is titled Caring for Adults with Intellectual and Developmental Disabilities, the Health Maintenance Exam, and will be presented by Dr. Brianna Marzolf. Dr. Marzolf is a graduate of the UM Department of Family Medicine Residency Program and is the MDisability Program's inaugural Disability and Health Fellow, where she is leading the charge for IDD care in the department. She is passionate about providing care for people with intellectual and developmental disabilities, and it's my honor to introduce her. Please, Brianna, go on and take it away.
Thank you so much, Tyler, and thank you everyone for joining. I am thrilled to be here today discussing the health maintenance exam for adults with intellectual disabilities. We will just jump right into things after that wonderful introduction. There's not much more to be said. I have, of course, no financial disclosures. The objective for our session today is to leave feeling prepared and confident in your ability to perform a health maintenance exam for an adult with an intellectual or a developmental disability. And so to help us get there, I want to start by saying, if you're here today and you're not feeling very confident in your ability to perform this exam, you're not alone. In 2019, Dr. Lisa Iazzoni out of Harvard did a study and found that only 41% of practicing physicians were very confident in their ability to provide the same quality care to people with disabilities as those without. And so to me, that's a bit of a shocking number. She surveyed over 700 physicians. And so I think this topic is important, and I'm really, really glad that you're all here and ready to learn a little bit. So we will do just a brief introduction to what intellectual disability is, and then we'll kind of go through our health maintenance exam step by step. We'll start with just some basic communication tips, and then we'll just briefly touch on medication review. And I say just briefly because if we're doing our patients justice, we should not be doing a complete medication review during their annual health maintenance exam. For most patients, we wouldn't do that, right? We would have a separate dedicated visit to go over their medications, and that should be the same for this population as well. We will go over up-to-date screening recommendations and discuss a focused review of systems and focused physical exam. Then we'll conclude with some specific recommendations for Down syndrome screening, and we should have time at the end, about 10 minutes or so, for some question and answers. So please, if you have questions throughout the presentation, feel free to put them into the chat, and then our moderator team will help us go through those at the end. So I just wanted to touch on the fact that I think a lot of these principles, we're going to be talking about intellectual and developmental disabilities, including learning disabilities, but a lot of these principles can be applied to other types of patients, those with dementia, Alzheimer's disease, stroke, TBI, even mental illness. A lot of these principles are applicable. Just very briefly, what is intellectual disability? According to the DSM-5, it is an impairment of general mental abilities that impact adaptive functioning in 3 domains, which determine how an individual copes with everyday tasks. And those domains are conceptual, social, and practical. A lot of the times, if you're meeting an adult with an intellectual disability, the diagnosis has been made, but that is not always the case. And so, one caveat I would say is that patients who are nonverbal, I don't think that necessarily means they have an intellectual disability. And we'll talk about why that is and ways to kind of augment communication in order to give them the best chance at doing some IQ testing or neuropsych testing. We shouldn't just assume nonverbal means intellectual disability. So I went through several sources to compile these recommendations. The main source that I used were the 2018 Canadian Consensus Guidelines. The United States does not have any great specific guidelines, but there was a literature review in 2007 that kind of reviewed current USPSTF guidelines and came up with some recommendations. Those are a little bit out of date, and so that's why I say I focus more on the Canadian Consensus Guidelines. And then through this talk, we'll talk a little bit about the National Health Services in England and their guidelines. And in a lot of ways, they are ahead of us in many areas. And we have a lot to learn from them, I think. So just briefly, some communication tips. I think we should consider not wearing our white coat when we're meeting patients with intellectual disabilities. A lot of times there's trauma associated with the healthcare setting, and just the stark contrast of kind of us and them wearing the white coat and then the patient not. I've found that patients do a lot better when we're just in kind of our general attire. When we talk with somebody with a disability, we should greet them the same way that we would anybody else. We should speak to patients like we'd like to be spoken to. It sounds obvious, but we should talk to the patient, not the caregiver. When we walk into the room, we say hello to the patient, and then we say, "Who's with you today?" in addressing their caregiver. We should be patient and let them set the pace of the conversation, and that often can take a little bit more time. And so we'll talk about my recommendation that every health maintenance exam should be at least 40 minutes long for a person with an intellectual disability. If we don't understand what's being said, we should let the patient know that, and we can ask for permission to kind of guess what they're saying. And I think we should make sure that we remember that none of us are perfect, and we should stay open-minded. And, if we make a mistake, we apologize and we learn and we do better next time. I'll say I'm somebody who really cares about disability health. And when I first met one of my mentors, Dr. Okunlami, he is a wheelchair user. And we had a wonderful conversation. And I said, "Okay, well, I'll walk out with you." And he kind of laughed and said, "I don't walk, I roll." And I felt so bad. But he didn't, and he corrected me in a nice way, and we have a wonderful working relationship. And now I've learned, and so I think we just want to have some good intentions, and it's okay if we say the wrong thing. We just have to be willing to learn and do a little bit better next time. So one important thing I think is to over communicate with the care team. So that means every time that I see a patient with an intellectual disability, I like to route the note to other people involved in their care team, their specialists. If they're lucky enough to have a complex care manager or a social worker, and then working and navigating with community mental health, I think is important as well. And a lot of the times we can email through, or we can connect with community mental health and then email updates that way. That's an extra step and it takes more time. And I think eventually the system will catch up and help us reimburse for those things. But that really is what patients deserve. And that's a way to improve quality of care, I think, is to just over communicate. As I mentioned before, all health maintenance exams. So here at the University of Michigan, I think a typical health maintenance exam is 20 minutes unless you're over the age of maybe 65. And then you have a 40-minute health maintenance exam. And we're working towards moving all health maintenance exams, regardless of age, to be 40 minutes for patients with intellectual disabilities. This is just a little bit of a plug for the disability accommodations tab that we have here at U of M, which is wonderful. You can see right first thing on the patient storyboard what disability accommodations they prefer. This is just a little bit more detail about what that disability accommodations tab looks like. And I would encourage all of us to use that tab. And if our patients haven't kind of gone through that tab, we should help them kind of decide what they would like providers to be seen when they open their chart. I also wanted to point out that when we're having Zoom calls, telehealth visits with patients, we can enable live transcription. And I think that this is something that we should probably practice for all patients. You know, it's sometimes difficult for patients with hearing impairment or auditory processing disorders to tell us those things. And so let's just make it easy and across the board enable live transcription for all of our video visits. I also would say that if patients you have a type of visual support aid, we should use it. I've seen too many times in the hospital, you know, on the inpatient setting where patients have their communication board out of reach and not accessible. And so one thing I'm working on is having communication boards accessible in all clinics for all patients. I think whether patients use communication boards or not, it can be a really great tool and can be a nice introduction to what a communication board is if we have them at our office. And so that's one of my long-term short-term goals, I hope, is to have those boards available in offices. But for patients who have their own, we should use them. This is an example of a health passport that the NHS recommends. And I think this is really neat. This is kind of helping us as primary care providers just recognize that we should be helping our patients prepare for if and when they are hospitalized. And if that's the case, they should have a quick little blurb to kind of just say, these are things you really have to know about me. I really, really love my communication board and I have to have it next to me. And I really, really don't like loud noises and I don't want the TV on in my room or things like that. Just little nuances about the patient. I think it helps. We never know when patients are going to be hospitalized or taken to the emergency room. And so to think proactively and preventatively, to have a little bit of, it doesn't have to look like this, but just talking to patients about some kind of document that they can have maybe laminated and ready for if and when they do need to go to the emergency room. I also think it's important to recognize that oftentimes we're caring for two patients when we're caring for patients with intellectual disabilities. And that would be the patient and their guardian or their caregiver. And so I think it's important when we see patients to recognize, do they have a legal guardian? Has that paperwork been done? And if not, how can we help getting them in touch with social work? And does that guardian have respite care? That's I think really important as our patients with disabilities age and their family members age. We need to be recognizing the caregiver burnout that can occur, and also planning for transitions as the caregivers age. Where might our patients with disabilities live? And so being proactive about those conversations, I think, is really important. Social work is great and I think would connect patients with these resources, but the two that I really want to highlight are the Area Agency on Aging and ARC, I think, are two really wonderful resources that if you had to write something quick in your patient instruction or patient discharge summary, those are the two resources that I would start with, in addition, of course, to a referral to social work. I'm not going to go too deep into this, but I just want to briefly point out that patients with disabilities, patients with intellectual disabilities should qualify for a significant amount of support through the state. And those two, the two main versions of support are through the My Choice waiver and the Habilitation Supports Waiver Program. There's a little bit of nuances between the two. The gist of it is that the patients are Medicaid eligible and need to require either nursing home level care or intermediate level care that can be done not at a nursing home or necessarily an intermediate care facility, but can be paid for to be done at the patient's home. And there's nuance to this as well, but family members, including adult children, can be hired to receive payment to care for their loved one. And so this is common, you know, that family members, they can't maybe necessarily work a full-time job because their primary job is caring for their loved one with a disability. And so I think just ensuring that they're connected with the Area Agency on Aging, with ARC, with social work in general, so that these questions can be answered and that they know that there are resources available. And I think that these slides will be available after the presentation, and so I won't go into depth, but this is just a little bit of the nuance between the My Choice waiver and the Habilitation Supports waiver. I mentioned that I don't think we're doing our patients justice if we try to do everything in one health maintenance exam visit. And you know, as the disability health fellow, I've been seeing more adults with intellectual disabilities, and I can tell you it's not possible, and it's not really equitable to do everything in one visit. It's too much, it's overwhelming, and we're not doing a good job doing everything. And so the one thing I think that we should do separately from the health maintenance exam is a comprehensive medication review. But because I have your attention here, and I just briefly want to mention that we should be looking at polypharmacy in these patients. And there's a movement through the National Health Service called STOMP, the National Health Service in England. STOMP stands for Stopping the Overmedication of People with a Learning Disability, Autism, or Both. And that's because we know that there are many adverse health effects from a lot of these meds. And so if patients are on, you know, multiple medications, we should know what the purpose of each medication is, and there should be an end date if appropriate. Oftentimes, patients are discharged from a hospital on new medications, and then that, you know, they're started at a specialist level, they're discharged from the hospital, and then they're passed on to us as the primary care providers for long-term management. And so we should take time to think hard about, you know, in particular for anti-epileptics, for mood medications and rescue medications, we should think about, why is it prescribed? Who's prescribing it? Is it helpful? Is anybody worried about side effects? Have we tried to go down in the past? And like you know, this is a time-consuming process. And so this, I don't think, should be part of the health maintenance exam, but this should be something that we think about during the health maintenance exam and say, come back in a month or two for a dedicated medication review. I just want to briefly shout out Steve Erickson, who is our wonderful pharmacist who specializes in the care for patients with intellectual disabilities, and he's doing some great work, doing some comprehensive medication reviews for patients in group homes. And what he's finding is that patients have an average of 2.4 plus or minus 1.5 medication-related problems. That's a lot. So he's going into group homes and he's finding that nearly every patient is having multiple problems with the medications that they take. Medications being taken without an indication, patients or caregivers saying, yeah, we actually don't really think this medication is working very well. Even the wrong dosage is being given. And one way I think to kind of combat that is to, you know, really give some power to the patient and the caregiver so that they should know why the medication is being used, how to take the medication, and what to expect, including side effects, and encourage them to speak up if there's a concern. I really love blister packs for patients. I think all patients really, you know, patients who are on more than 3 medications could really benefit from blister packs. I had a patient with severe depression who had a heart attack recently and was hospitalized and started on 6 new medications in the hospital. And that's hard for anybody, let alone somebody who's depressed and who is now not feeling well and is now, you know, has 6 new meds. And so working with the pharmacy or having your medical assistant work with the pharmacy to create a blister pack, I think is a really useful thing. I wanted to highlight one of the findings in Steve Erickson's comprehensive medication review of the group home found a patient who was having new loose bowel movements that were leading to fecal incontinence. And the group home was having staff leave because this was becoming such a problem. And as we know, finding caregivers is really difficult. You know, they're not paid enough, and it's a really, really hard job. And so to lose staff because of something like this is really is something we should try to avoid, and let alone the patient, you know, being, I'm sure, embarrassed and uncomfortable. And so on medication review, we found that metformin was started 3 months prior. And so that is known to cause loose bowel movements, and that is a simple fix. And so this is just to highlight that anytime there is a new symptom or a new concern, doing a comprehensive medication review, I think is a really great idea. I'm going to skip this next part for the sake of time here. So the next part of our health maintenance exam should be to assess mobility status and support. And we want to promote independence in every way that we can. And so to do that, we have to consider, you know, modifying the environment to make it usable and accessible for the patient. I really love the in-home occupational therapy assessment referral that we have here at U of M, where occupational therapy actually goes into the home and can make recommendations about grab bars or more accessible showers, things like that. I also want to point out that, you know, Medicaid will cover a new wheelchair for patients every 5 years, which I think is a problem in a lot of ways. People lose weight, they gain weight, they grow, they age. But we should know that adjustments can and should be made in the interim. And so utilizing our PM&R colleagues and our their wheelchair support staff, I think, is something that we should encourage. And so when you're doing your physical exam, being aware of skin integrity and being aware of, does the patient look comfortable? Does the chair look like it's functioning appropriately? Is it doing what we'd expect it to do? And if we're not sure, if that's hard to assess in a health maintenance exam, have them be seen by physical medicine and rehabilitation for a visit or two. I think as we think about patients with dementia, and we think about ways to limit delirium, and we think about making sure that all senses are kind of firing on all cylinders to the best of their ability. And so for patients with intellectual disabilities, we should be thinking about the same things. We should be making sure that their vision and their hearing are supported in every way, and knowing that they may be less likely to tell us if they're having some vision or hearing difficulties. And so we should be doing regular eye exams every 1 to 2 years. And we should be assessing annually for hearing changes. I think cerumen impaction is very, very common. I would say nearly every patient I see with an intellectual disability has a wax issue. And one thing that I've learned from ENT that I really like is using Colace, which we normally think of as a stool softener. It's safe to use daily as a way to kind of prevent cerumen buildup. And so you can, I always have trouble with insurance covering the liquid Colace. And so you can use the Colace capsules and kind of poke a hole in each capsule, squeeze a little bit into the ear before the shower, and then rinse out in the shower. And that slowly kind of gets at the earwax and prevents buildup. And I think typically we think about Debrox for that kind of thing. Debrox, we really should only be using for several days at a time. It can't be used daily. It can cause some irritation. And so I would say there's very few contraindications to Colace, and unless ENT says no, I think that that's a pretty safe thing to do. Again, referring to audiology assessment is important. I think sometimes we wonder, well, how is a patient going to participate in the audiogram? There's ways that audiology can do things that I don't fully understand. We can test hearing in newborns, and so there doesn't necessarily need to be participation from the patient. I think it's worth a referral to audiology and an evaluation. And there's cues that we can kind of pick up on. I just saw a patient the other day in clinic who in the office was holding his iPad, up to his ear. And I said, do we think that maybe we should assess his hearing? And his dad said, oh yeah, you're right. He's always holding the iPad up to his ear. So just supporting vision and hearing. And then speech is really important as well. So if you think about, if it's difficult to communicate, that can lead to behavior outbursts and challenges because patients can get frustrated. And so there are, technology is always changing, and there's new communication interventions such as augmentative and alternative communication devices, AAC devices. And this is an example of one of those devices. I care for a lot of patients who are 40 or 50 years old and who haven't really been assessed by a speech therapist since they were in school, which was, 20 years ago. And there's new devices that have come out since then. And so I really love referring to speech therapy to see if there's any type of device that might benefit the patient. And in patients who are minimally verbal or communicate a little bit can still benefit from these devices. And so I think that's an important thing to consider. We should be doing our best to help patients verbalize their thoughts and feelings in every way. Exercise is very, very, very important. And I would like to, I'm working on working with our adaptive sports team to come up with a list of resources. I'm always learning about new resources and new things for patients with intellectual disabilities and physical disabilities in the area. And the list is ever kind of changing and growing. And so that's something that I would love to have included in our MDisability website. Some more simple kind of resources for exercise. But I would say that a physical therapy referral is a good place to start. And some patients, I kind of frame it like you get to, work with a personal trainer for a period of time, and patients are excited about that and they like it. And so we know that these patients are at risk for they're on medications that can cause metabolic syndrome and weight gain. And so we really need to, not just for their physical benefit, but their mental benefit too, have them be moving and be around other people. And just, I can't emphasize how important that is. And another one of my short-term goals is to have some more accessible resources for you all. But easy thing to do is at least refer for a physical therapy evaluation. Employment and volunteer opportunities, I think, are, everybody does a little bit better mood-wise when they have a purpose and they have something to look forward to. I love Michigan Rehabilitation Services, and I think it's a great place to refer. I just saw a patient the other day whose biggest stressor was money. He just really always worries about the way that he budgets his money. And I said, me too. We never really get good classes on that in high school. And now you're 32 years old. And why don't we have you see the folks at Michigan Rehabilitation Services and see if they can give you a couple lessons on accounting, and maybe that would help your mood and, be a good thing for you. So they offer all kinds of services, including job training, and opportunities for volunteer work as well. Sleep. Think if we don't sleep well, we're crabby and we don't feel very well. So, and not to mention it's not great for our heart, our lungs, just our overall well-being. A lot of patients that I see, particularly patients with Down syndrome who have kind of the larger tongue and the just the facies that predispose to sleep apnea. We should be screening for sleep apnea in most of our patients. And I think starting with a home sleep study probably is the best way to do it, because everybody's more comfortable in their home. And if the home sleep study is negative and you have really high suspicion, then we should pursue an in-lab sleep study. I think I run into this problem with patients in the general population all the time. It's hard to tolerate the CPAP. Some people love the CPAP. My cousin Will has Down syndrome and is religious with his CPAP, and he loves it and he feels better and he does great. And I'm trying to convince my dad to take a cue from my cousin Will, but I would say the majority of patients don't love it. And it can take some time to find the right mask. And so I'm not suggesting this procedure for all patients by any means, but I just want you to be aware that if patients do not tolerate a CPAP, there are other options for them. And I would refer to sleep medicine rather than just say, well, we tried, we tried one mask and I guess that's it. This is an interesting hypoglossal nerve stimulator that basically helps the tongue protrude while you're sleeping, and is, invasive in that there's a procedure required, but then non-invasive in that there's no mask needed to be worn every night. I don't know that this is great for every patient, but I would just encourage a referral and kind of really not just giving up on the sleep apnea treatment, and working with our colleagues who know some other resources. Okay, so briefly touching on sexual health for patients. I'm just learning more every day. And one thing that is new to me is something called catamenial seizures, which are patients who have a known seizure disorder, who have an increase in seizure frequency during their menstrual cycle. So that's one reason to kind of discuss and offer options for contraception for some patients. For other patients, menstrual cycles lead to behavior changes. Patients who have OCD or who have autism in particular, sometimes really, really have a hard time around their menstrual cycle. And menstrual suppression can help with cleanliness. It can be difficult for caregivers and care teams, and can help prevent anemia. We're lucky enough at U of M to have a wonderful clinic for women and adolescents with intellectual disabilities, and I've been able to work with them and learn from them. And I do see that oftentimes families say, well, what about a hysterectomy? Why don't we just get rid of the uterus and then there's no problem? And I would say that hysterectomy doesn't prevent abuse. It doesn't prevent the cyclical behavior changes or the seizures that are associated with menstruation, because the ovaries are often left intact. And then it comes with risk of pelvic organ prolapse and ureteral injury, which I've seen on the inpatient side, ureteral injury in particular. And so I think, hysterectomy isn't a no, but I think that there's other places to start. And so if families inquire about hysterectomy, those are some of the counseling that I give. And so I think our goal is menstrual suppression, and if that's the patient's goal. And so using continuous combined OCPs is probably the most simple place to start, knowing that there will be some breakthrough bleeding in the first several months. The progesterone-only pill can be tried and has a little bit higher risk or higher ability to suppress menses in this population than others, it seems, but only about 40% actually have full menstrual suppression with the progesterone-only pill. Caution about some of the other options. The Mirena IUD only works locally, so won't necessarily improve seizures, but is a really, really great option for a lot of patients. And if that is done, oftentimes patients do need to be sedated. And so we would talk about later in the presentation about trying to coordinate care under anesthesia and do, multiple things at once under one sedation if possible, as in blood draws, immunizations, other things. Depo-Provera, I think I would not recommend. I've seen significant weight gain, and we know that it causes risk of lower bone density in a population that's already at risk for lower bone density, especially those with reduced mobility. I don't think that I would recommend the Nexplanon either. In the general population, I see that it's associated with irregular bleeding in 33% of people or so. I think that I would, if I was going to use a progesterone-only option, the Mirena IUD I think is the best. And then the progesterone-only pill is another great option, kind of maybe in the interim leading up to the Mirena IUD. But the use of continuous OCPs has been really helpful for a lot of patients, just having to, weighing how mobile are people. If they're really immobile, maybe we avoid YAS or the OCPs that we know are associated with higher risk of clot. So each case is unique, and we have to weigh individual risk factors. And I think it's also just wanted to say, don't forget to ask about postmenopausal bleeding. I think this is a population who may not know to mention that if they are having bleeding. So we really want to be kind of specific in our review of systems questions that we ask. I'm not going to go too in depth here, but I will say that this population is very at risk for sexual abuse and trauma. Some studies report incidence in children from 15 to 52%. And so this is relevant because we have to educate patients about what is appropriate and what isn't appropriate. And we have to think about contraception in that regard as well as cervical cancer screening and HPV testing. We have to just be aware of what the world is like and that these patients are at high risk. Girls with intellectual disabilities tend to start their menstrual cycles earlier than average. And so starting that discussion sooner than you think you might need to, I think is a good idea. I have found that, so I don't do this the first time I meet patients, but I do think we should be doing breast exams and GU exams in this population. Breast exams, if the patient is, they're unlikely to do their own self-breast exams. And we know that that's the best way to do an exam. We know that clinicians aren't great at finding abnormalities, and mammogram is the gold standard. But for patients who are unlikely to do their own breast or testicular exams, we should be doing those. Educating that only your doctor should do this. It's difficult when patients need kind of daily hygiene care and they're having changing, others are helping them change. I think it's confusing for patients, and I think that they're really at high risk for abuse. We know that they are, and so I think we like I said, I don't do the breast or the testicular exam when I first meet the patient. I like to build up some rapport, but I think that's a good time to kind of talk about who should be touching those areas and what's inappropriate. There is a social worker here at U of M who sees patients, I believe, from all around in her own clinic at the sexual health counseling clinic in Ann Arbor. And her name is Manisha Finkel, and she is just wonderful. And she will meet with families and patients to help with these discussions about sexual health. I'm going to share some other resources, but that's another really wonderful resource. So just briefly, I think some quick education that you can give patients. No, go, tell is the big one. If you think something is abnormal, tell them, the patient should say no, they should leave the area, and they should tell somebody. This idea about circles, where the people who are you have your private space, and the people who are very closest to you, being your family, can hug you and be in that kind of private space. And as you know the people less, so your school bus driver is going to be far out in the circle, we need to have more space. And I think that this is easier said than done, and this is hard when, like I said, when patients require kind of help with their ADLs and they're changing, but we have to be trying to have these conversations. I also think it's important to try to have a few minutes, a short period of time alone with the patient to kind of ask if they're, an easy way to ask about abuse is to say, are they frightened or are they being hurt by anyone? Okay, moving into cancer screenings. So it's important to discuss patient goals. If cancer treatment is not necessarily within the goals of care, we should be sharing the information about symptom management and palliative care with caregivers. Breast cancer, maybe we don't want to treat breast cancer, but maybe we don't want somebody to suffer from bony metastases that are painful and awful. And that maybe has to be said, if we just defer, caregiver says no mammogram, caregiver says no mammogram. Okay, but we should know what could happen. Cervical cancer screening, I think, is difficult oftentimes in this population. It can be difficult to do the pap smear. And so if patients, whether they're sexually active or not, because of the high risk of abuse, we really should be doing cervical cancer screening in everybody. And I think the future is moving away from cytology and moving towards HPV testing with a use of a biomarker, which has yet to kind of come to fruition. But I think if we can't do a pap smear, we can discuss the pros and cons of doing HPV testing only. And we can have patients do a self swab if they'd like, or we can, it's a lot easier to do a swab than to do a whole speculum exam. And so if the HPV testing is negative, that's great. That's really reassuring. We can rescreen in 5 years with HPV testing. If the HPV is positive for high risk HPV, 16 or 18, then we've kind of skipped the trauma of the pap smear, and now we need to refer for colposcopy, which will probably need to be done under sedation. If it's positive, if HPV is positive for one of the other types of HPV, then now we're in a gray zone, and now we do need to think about a speculum exam for cytology until a biomarker is available to help triage these patients. And we should just, rely on our gynecology colleagues if needed. And as I mentioned before, if we're going to do an exam under sedation, we should coordinate with other upcoming procedures: IUD placement, dental work, Botox injections, G-tube replacement, baclofen pump, work. This is easier said than done. It's actually difficult to do. But I have found that the surgeons and the anesthesiologists at U of M are really wonderful and do go out of their way to work with us on these things, because these patients are often on a lot of meds, and sedation is not difficult, or is not easy, and we want to limit how often we have to do those things. Breast cancer screening, I would say there's different recommendations from different groups, including ACOG and the AAFP. I think, based on my review of the literature, I would say starting screening earlier at the age of 40 rather than 50 is a good idea, because patients with IDD are more likely to have risk factors associated with nulliparity. So starting screening earlier and then screening every other year, I think, is appropriate. Doesn't necessarily have to be annually unless patients tolerate it really well. I think one important note is when scheduling the mammogram to schedule with an extra technician if possible, to consider a breast ultrasound if that's a little bit less painful, I think, than mammogram. It's better than no mammogram, but it's not the gold standard. And then just to highlight, if we do have patients who are wheelchair users, they need appropriate accommodations, and that the mammogram machine needs to be adjusted so that the patient can remain seated. And we should encourage patients to ask about that when they schedule their mammogram. This is just some comments about patients from the National Health Service who were sharing that it really helps a lot if the doctor tells us what's going to happen when we go to get the mammogram. It's important to educate our patients and kind of share with them what's coming up. Okay, colon cancer screening, I would say it's a wonderful thing to have the opportunity for the Cologuard. It's less invasive, and if a patient qualifies, has no strong family history of colon cancer, isn't having blood in their stool, we should start with the Cologuard. And then if needed, if a colonoscopy is needed, we can try to time other things with that if possible. I think in practice, that one is harder to do. I would say it's easier to time things with dental work than with colonoscopy, but it's doable. Prostate cancer screening, I think I would say is the same as the general population, but we should be aware, in particular with this population, about if the PSA is elevated, are we going to want to do invasive testing to pursue that, or are we going to want to track more over time? But again, prostate cancer can be very painful as well in terms of metastases, and so we're just thinking of quality of life oftentimes for these patients. Osteoporosis screening. This is one thing that I found interesting in the Canadian guidelines. It's recommended for men and women beginning at age 40. And so who have an intellectual disability. They have all kinds of increased risk factors, including reduced mobility, use of anticonvulsants, early menopause. And I so far have not had pushback from insurance companies when I order these screenings early. And sometimes in the comments, I'll just write per the Canadian guidelines, or I will share their risk factors and why early screening is recommended. The HPV vaccine, of course, is recommended for all patients, whether they're sexually active or not. And I think this is interesting. The pneumococcal vaccine and our BPAs for pneumonia won't flag for this, but any patients 19 to 64 who have a condition that affects breathing or swallowing meets criteria for vaccination. A lot of our patients are at high risk for aspiration pneumonia and are on some type of dysphagia diet. And so those patients should be offered the pneumococcal vaccine. Dental care, really, really, really important. I've found that our dentists are great. Actually, Delta Dental just opened up a new special needs dentistry clinic in Ann Arbor, and they take Medicaid. And so please refer your patients to them. I would say it's worth the drive if your patients are in need of that kind of dental care. Dental school and the dental education profession is actually the only education profession, like healthcare education profession, that requires learning about patients with disabilities and requires testing on their board exams. And I really think it reflects in how great of a job they do with this population. Labs, I would say, we know that these patients are at higher risk for metabolic syndrome, and so lower threshold to screen for diabetes and hyperlipidemia. Thyroid testing should be done annually for patients with Down syndrome, patients taking lithium or antipsychotics. Calcium and vitamin D supplementation is recommended for most patients unless contraindicated, like in Williams syndrome, especially if patients are on antiepileptics. And I do think our neurology colleagues are usually pretty good at least recommending that in their note that you know, if you're on an antiepileptic, you should be receiving vitamin D supplementation, but it's often not prescribed. And if patients live in group homes, we know that everything that's given to them has to be prescribed. And so I think it kind of falls onto the PCP often. If we're going to be drawing labs, it's nice to help our CMH, our colleagues at CMH, or our colleagues who are managing lithium or anti-epileptic drugs, and draw those levels if needed. So I'm always kind of looking up, does this need a trough level? Lithium typically does a morning trough level, but that's one way to reduce pokes for our patients. A poke plan is something that we should consider for all of our patients. I think arranging for the patient to have their blood drawn often on a different visit than the day that they do the health maintenance exam can be a good idea. I like to prescribe EMLA cream, which is a numbing cream that you can put on the bilateral antecubital fossa 30 minutes before a blood draw, wrap it in saran wrap, and then the patient can look away and hopefully have some numbing in place. Of course, if we need to use short-acting benzos, that has to be done. I think it'd be great to have a place in the chart to kind of highlight a poke plan for a patient, and that's something that I'd like to work on in the future. I know we're running out of time here, and I'd like to give at least a couple of minutes for questions. So I will just kind of breeze through the physical exam, but say that we need to be a little bit more thorough than we would typically, because, and so by that, I mean, we should look at everybody's ears for cerumen. We should look at their teeth. We should listen to heart and lungs. Skin exam, I think, is really important, particularly evaluating for pressure injuries if they're immobile. I think I don't look at every patient's feet, but for patients with IDD, I typically do. I think it's a really good indicator of their general quality of care. And oftentimes we find things that can be causing pain, like fungus or ingrown toenails, things like that. And then we do I did mention that I do think a breast and a GU exam is important in this population who often are not able to do their own self-exams. In terms of review of systems, I think we talked about assessing for sleep apnea in all of our patients. A really big one is assessing for overt or silent aspiration and signs of difficulty swallowing. So are they throat clearing after swallowing? Are they coughing or choking or drooling after eating? Those kinds of things. And I don't typically ask that in the general population. Of course, asking about constipation, postmenopausal bleeding, any changes in ambulation, Any contractures or dystonia, those kinds of things need to be managed quickly because they get worse and they are harder to reverse if they're not addressed urgently. And so if there are contractures that can be causing pain, we should get them in with PM&R as soon as possible. I think that I can kind of summarize the next little part here by just, this is kind of less health maintenance and more of an acute concern. But if there's a change in behavior, we really have to be thinking about why. Is there pain or is there discomfort? And so again, I think these slides will be available, but big things, constipation and acid reflux, I think are the biggest causes of pain that patients sometimes can't verbalize. Menstrual cramps being another one. Are patients frustrated because they can't communicate? That would cause a change in behavior. And we've discussed the importance of vision and hearing screening and getting them in with speech therapy. And we need to evaluate for abuse. We need to make sure that, and this is a kind of all part of our health maintenance exam in general. We should be asking about any changes of their environment or their care team, and making sure that their environment doesn't over or understimulate them. And then lastly would be medication side effects. We can't just assume that a behavior change is due to a medication. We have to go through those other processes that I mentioned: pain, social environment, those kinds of things. For patients with Down syndrome, this is the last thing I'm going to say so that we have 5 minutes for questions. We should have a low threshold to screen for sleep apnea. We should be checking thyroid testing every 1 to 2 years. We should be aware that patients with Down syndrome are at a much higher risk for developing other autoimmune conditions, not just thyroid. So that includes celiac disease. Anytime if there's any weight loss, diarrhea, oftentimes skin changes can present in these patients as a thyroid issue or a celiac kind of malabsorption problem. And then atlantoaxial instability. Oftentimes the Special Olympics will ask for a cervical spine X-ray. Really, it's only needed once after the age of 3 when their spine has kind of matured. But we should be asking every year about signs of spinal cord impingement, such as head tilting to one side, trouble moving the upper extremities, those kinds of things. And then I think we'll have to skip through this last little bit because I just always am optimistic, a little overly optimistic about what we can include. And I would just like to thank you guys for your time and share. This is my cousin Will, who's just the absolute greatest. He was the ring bearer in our wedding, and you can see here he's in the middle with my husband and my brother, and there's bunny ears involved in every picture with Will. But he's really been an inspiration to me, and I love him dearly. And he's really helped me kind of learn a lot about this population, and I'm really lucky to be here sharing it with you all. Okay, 5 minutes for questions. I don't know, Tyler.
Yes, I will help with moderating the questions for you.
Okay.
I do just want to give some shout outs that came in from the chat. One was a parent of 2 adult sons with ASD and IDD saying that I so appreciate all of the great info. Brianna is awesome. And I completely agree with the sentiment. There were some recommendations provided by Dr. Michelle Mead on adaptive sports medicine clinics and recreational therapists here at Michigan Medicine. I have gone on and shared those through the Q&A. That way all attendees can see them. And also Liz Katz did share them in the chat. One question was about pharmacy blister packs. What exactly is the process for obtaining those blister packs? Is it a request to the local pharmacy, or is it a discussion and the provider adds that into a script? How exactly does that work?
When I've done it, it's been a discussion with the pharmacy. So I haven't had to change any medication. I haven't had to send any new meds. It's a call to the pharmacy, and your medical assistant may be able to help with that as well. The pharmacy will just go through, they'll want to make sure that they know the timing of the meds. So, if you send a script for once a day, Lexapro, they may ask you, would you like that given in the morning or the evening? And so I think one, I guess this is a good time to note that we should be really specific with the prescriptions that we write for patients with intellectual disabilities, particularly if they're at a group home. We should say, if we're writing an order for a cream, it should not say apply to affected area. There's a different caregiver every day. They might not know where that area is. It should say apply to, foot. That's the problem. So I would say the only time I've had issues with the pharmacy with blister packs is when they need a little bit more specific information about timing of meds, but it's usually a very quick process, less than 5 minutes. I call and they run through the meds and I say, yep, that's a good one for the morning. That one should be at night, that kind of thing.
Great, thank you. And I just want to add, Dr. Steve Erickson, the pharmacist who focuses on IDD care practice, mentions that not all pharmacies can provide blister pack services. And so patients and providers may need to look at other pharmacies that would offer that service. Thank you, Dr. Erickson, for that.
True.
Another question is, do you have a link or additional guidance regarding menstrual suppression? This is the first time that this participant has heard about it. And it's commonplace / as healthy as having a routine menstruation.
Yes, it is. There is actually, you can do continuous menstrual suppression with no need to have kind of a breakthrough bleed. Because when you're on the continuous OCP, you're not getting that buildup of the endometrium that causes that people can be concerned about. So yes, I can share. The gynecology department has a wonderful handout that they give to patients when they see them about menstrual suppression, and they've shared that with me. And so I'm happy to share that with everybody. I don't know the best way to get that information out, but yes, I have a great handout on that.
Great. Perhaps what we can do, since the webinar will be available on the MDisability website, is having like a link to supplemental materials in addition to the video.
Great.
And then that's all of the Q&A from participants. I did just have one here. So a lot goes into this health maintenance exam. Like you just did a 1 hour long presentation on everything that a provider needs to be paying attention to. Can you share some of your work and interest in developing clinical decision support tools for caring for patients with IDD, such as the dot phrase that you've been able to create?
Yes. Oh, thank you. I would love to share. So actually, after I gave this presentation about a year ago, I was seeing a patient with an intellectual disability, and I was kind of flipping through to my PowerPoint in my note and trying to make sure everything was included. And I thought, this is nobody has time to do this. And so wouldn't it be nice, and wouldn't it be a great form of continuing education for providers who might not all have time to attend a seminar like this, if when they saw a patient with an intellectual disability, a template kind of popped up and showed them exactly what to ask and what review of systems questions to ask. And, oh, this patient is eligible for a pneumonia vaccine. And, oh, they should be screened earlier for osteoporosis. And so Tyler and I are actually working on a project where we'd like to kind of have the chart help flag a patient with an intellectual disability coming in for a health maintenance exam, so that that template pops up for the provider and is there. And then with that, I would love to have some after visit summary information written at the level for the patient and the caregiver. So that is in the works. I've mentioned lots of my short and long-term goals. That's more of a short-term goal. And I think right now, if you're a provider at U of M and you use the .phrase.IDD-HME, you'll get a pretty good summary of what we've discussed. But I would like to make it even more intuitive, I guess, for people, so that they don't have to remember to use that dot phrase. And so we're working on developing that kind of template, so that as soon as a patient comes in for a health maintenance exam, those things kind of just pre-populate in the chart. Do you have more to add about that, Tyler?
No, I think that was a great summary. It's related to this, and this will be our definite last question. Janice Ferrari asked that they appreciate this comprehensive review. Do you send out any information via the portal in advance to prepare patients or caregivers for their annual exam?
You know, I think that is a wonderful, wonderful question, Dr. Ferrari. I think that we have to be really mindful about what kinds of screening questionnaires we send out, because whether they're being answered by the patient or the caregiver. And so those are things that are in the works. I more so think about giving material after the visit, but I'm so glad that you shared that, that you're right, that maybe I'm going to be asking a lot of questions that it would be helpful to kind of prepare families for what's going to be discussed. And so that's a great point, and that's something that I'll consider further. At this point, no, I don't send anything out in advance, but I love that idea. I think that's a great point.
Thank you so much, Dr. Marzolf. And can you let us know what your email is, just in case any attendees want to reach out to you directly?
Oh, sure. Why isn't it on here? Yes, it's a very strange email. It is BA. Can I type it?
I'll type it for you into the chat. Yeah.
Okay. BAMARZOL at med.umich.edu. And I'll add that to the slides for the future presentation. Thank you all.
Perfect. Thank you again, Dr. Marzolf, and thank you everyone for attending this provider webinar series hosted by MDisability. We hope you have a great rest of your day, and we'll see you at the next webinar. Thank you.
Thank you. Bye-bye.